All right, so forget the whole debate over these massive long-term healthcare spending cuts for a second.
Uh-huh.
We're diving into the $50 billion federal fund that the Trump administration used to, well, kind of secretly leverage market-driven conservative policy changes in all 50 states.
It really is a masterclass in using, the power of the purse.
Yeah.
What you're going to learn in this deep dive is how the Rural Health Transformation Program, or RHTP,
Right.
which was this $50 billion grant under the One Big Beautiful Bill Act, the OBBBA, how it just completely transformed.
It was pitched as a simple bailout, right? The last-minute thing for rural hospitals.
Exactly. But it became one of the most powerful political tools we've seen for forcing state-level legislative reform in, decades.
We dove deep into the sources for this one KFF analysis, CMS announcements, even internal state planning documents to figure out how this happened.
The stakes are just monumental.
I mean, you have to remember, the OBBBA slashed federal Medicaid spending by $911 billion over 10 years.
A staggering number. And for rural areas alone, that's an estimated $137 billion cut.
So this $50 billion RHTP was basically a conservative offset. It was added late in the game just to sweeten the deal.
And this is where the policy pivot happened. The administration was absolutely explicit about this. This money is not a simple check to backfill operating budgets for struggling hospitals.
No.
The Centers for Medicare and Medicaid Services, CMS, they made it very clear this program is a mechanism to fundamentally rebuild and reshape healthcare.
Okay, so if the purpose wasn't stabilization then, what was it?
The focus was on promoting what they called insurgent technology and innovation models, not propping up incumbent hospitals.
Insurgent technology.
Yeah, they're focused on right-sizing the system. I mean, this is a core conservative philosophy.
Yeah.
Use a one-time injection of capital to drive market efficiency, force modernization, and, get rid of outdated services.
Positioning the whole system to operate with way less federal money down the line. Okay, let's unpack the financial reality here first. Because you really have to understand the context of that massive original cut to appreciate what this fund is doing.
That financial context is absolutely critical. Rural hospitals, they rely so heavily on public payers, Medicare and Medicaid.
And they were staring down the barrel of that estimated $137 billion cut.
Right, just in rural communities over 10 years.
And this $50 billion fund, the RHTP, it's not even close to a full replacement.
Not at all.
Our sources show it only offsets about 37% of that cut. And it's temporary. It only lasts 5 years, from fiscal year 2026 through 2030.
And that temporal mismatch, the timing, that is the most important financial detail here.
Why is that?
Because the largest, most painful part of the Medicaid cuts, we're talking nearly 2/3, 64%, they're backloaded. They happen after the RHTP funding is gone, after 2030.
So this fund was never meant to save today's system.
No. It was designed to force states to transform their systems so drastically that they could operate with that permanent, deep loss of federal money later on.
Wow. So it sounds like the administrative lever was pulled right away. I mean, if the money wasn't for stabilizing these vulnerable hospitals, and we know 44% of them already had negative margins, what was it meant to build?
It was designed to build a leaner, more market-driven system. The administrative side just overrode any legislative talk about simple stability.
So when CMS says right-sizing the system,
They mean using technology to replace physical infrastructure. Think remote diagnostics, centralized data hubs, pushing value-based care models.
anything that reduces the need for expensive brick-and-mortar hospitals that might be half empty.
Exactly. It's a harsh form of tough love, really, all designed to promote long-term fiscal health.
So how did they structure the $50 billion to make sure states actually followed this mandate while also rewarding them for adopting other conservative policies,
They used a really effective two buckets analogy for the money.
like a college scholarship?
It's a perfect metaphor. The whole $50 billion is split into two equal pools. $25 billion for a baseline grant and $25 billion for a merit score.
Okay, so bucket one is the guaranteed grant. This first $25 billion is distributed equally among all 50 states that got their application approved.
Right, and that gives every state a baseline floor. It doesn't matter if you're Connecticut with only 3 rural hospitals or Kansas with 90.
If you got approved, you get the same base share from this first pool.
It was a smart political move.
Yeah.
It ensured buy-in from smaller states that don't have a huge rural footprint.
But then you get to bucket two, the merit scholarship. This is the other $25 billion, the discretionary half. And this is where it varies dramatically based on a custom scoring system that CMS created entirely on its own.
And this is where the administration's discretion becomes real leverage. The scoring for this bucket is split 50-50. Half of the score is based on objective rural metrics. You know, a state's total square mileage, the size of its rural population, things like that. That part is pretty straightforward and data-driven.
But the other half, the other 50%, that's the technical score, and that's the policy lever.
That's the one. This technical score is all about how closely a state aligns with the administration's specific agenda, which they call the Make America Healthy Again agenda.
And since all 50 states got their applications approved,
the real difference in the money they got came down almost entirely to that technical policy score. For the first year, fiscal year 2026, the average state award was around $200 million.
But the range is what shows the real power here. New Jersey, which scored poorly on the policy stuff, got $147 million.
That is a low end.
While Texas, which went all in on the policy changes, pulled in the maximum award, $281 million.
That's a difference of $134 million in just the first year. That's a very high price for not getting on board.
A very high price. And that leads us right into this Make America Healthy Again scorecard, this menu of reforms that states were pushed to adopt.
States earned those critical points and the millions of dollars that came with them by committing to these specific pro-market reforms.
Okay, let's dive into that scorecard. Because some of these incentives, they go way beyond just hospital operations.
Oh, for sure. The first big one is rewarding states for committing to SNP waivers.
So changing the food stamp program.
Right. States agreed to restrict what people can buy with those benefits, prohibiting funds for things like sugary drinks. It connects health funding directly to personal responsibility and nutrition, a huge priority for this administration.
And then there was this massive incentive for deregulation, specifically reforming or even getting rid of certificate of need laws or Con-N laws.
Yeah, that was a big one.
For anyone who doesn't know, what are con laws? Why were they targeted?
So con laws require state approval before you can build a new health facility or expand a service. They were supposed to curb spending, but the administration sees them as anti-competitive.
Barriers to entry.
Exactly. So by rewarding states that got rid of them, CMS is using federal dollars to promote free market competition. The idea is you let more competitors in, you increase supply, and theoretically prices come down.
They also incentivize things that push toward individual health accountability, like making schools bring back the presidential fitness test.
Right. That one takes effect in year 2. You're literally using health funding to drive a PE policy in public schools.
And finally, scope of practice expansion.
This is a vital one for efficiency, especially in rural areas. States got higher scores for loosening regulations so that nurse practitioners and physician assistants can use their full training without, unnecessary doctor oversight.
So they can prescribe medication, run a clinic.
It just empowers skilled professionals and cuts down on bureaucratic bottlenecks when there aren't enough doctors to go around.
So the state has to pass a bill to restrict SNP, another to reform Con-N laws, and maybe a third to expand scope of practice.
All on a timeline, or they risk losing the money. It's basically a 5-year contract. The state is the contractor, and they only get paid when they deliver the policy changes.
That's a perfect analogy because the funding isn't just a one-time thing.
No, it's performance contingent. The money for years 2 through 5 from that discretionary bucket depends entirely on follow-through.
So if a state promised to, say, pass a SNP law and then doesn't,
the administration can actually take back the points and reduce that state's funding in the following years. It guarantees follow-through. It makes the state legislature financially accountable to the federal administrative agenda.
So with all these mandates, transformation, technology, policy alignment, how are states actually planning to spend this money?
Well, states had to commit to at least 3 of 10 allowable categories, and they all prioritize innovation over just, keeping the lights on.
Things like AI chatbots, value-based care models.
Yep. And technical help for IT and cybersecurity upgrades.
And there are strings attached, especially around workforce.
A big one. If a state uses the funds for recruiting clinicians, those new hires have to make a 5-year service commitment to that rural community.
Which promotes actual long-term stability, not just a short-term bonus.
Exactly. Let's look at Missouri as a case study. They're facing an estimated $23 billion loss in federal funding over a decade.
And they were awarded $216 million in the first year, a high score.
The very high score, reflecting their commitment to this transformation agenda. And their plan is all about innovation and efficiency.
Not propping up old systems?
Not at all. Their plan has 5 pillars, including a huge shift to performance-based payment models. So instead of just paying providers for doing stuff, the old fee-for-service model.
They'll reward them for outcomes, like reducing ER visits.
Exactly. Or controlling chronic conditions. It shifts the whole payment system toward efficiency and preventive care.
And they're also creating 30 local community hubs for data sharing. What does that actually look like?
It means using technology to coordinate care across clinics, hospitals, public health departments. For a provider, it means less paperwork and better info on your patients. For you, the patient, it means your records follow you seamlessly wherever you go in that community.
So Missouri is a good example of a state that really embraced the spirit of this.
They did. Their leaders specifically noted plans to use AI tools, like ambient listening, to streamline administrative tasks for clinicians. It shows a real commitment to modernization.
But we have to talk about the real tension this creates for rural hospitals that are facing, immediate collapse.
Absolutely.
The American Hospital Association, the AHA, they urged CMS to prioritize direct payments to hospitals for financial stability. They pointed out that nearly 48% of rural hospitals were losing money in 2023.
And that tension is the core conflict of the entire RHTP. The administration is focused on long-term systemic transformation, which, is fiscally responsible in the long run.
But it's an existential threat for a facility facing bankruptcy now.
It's a philosophical divide, really. Should the government support struggling incumbents, or should it incentivize a new, more competitive market? The administration clearly chose the latter.
And the whole program just reinforces how sweeping this kind of administrative discretion is. The law explicitly says that CMS is not required to publish detailed information on why some states got more money than others.
That lack of transparency is a feature, not a bug. And what's more, the final funding decisions are explicitly not subject to administrative or judicial review.
Wow.
Which means the administration has complete, unchallengeable authority to move fast and reshape policy without getting bogged down in lawsuits or bureaucracy. The federal government gets the final word.
So what does this all mean at the end of the day? We've seen $50 billion in federal money used not really to save existing hospitals, but to force states to adopt these conservative, market-driven policies.
It means this fund is a hugely powerful, real-world example of the federal government using competitive grants to leverage specific legislative action at the state level. It proves that targeted, performance-based funding can be a very potent tool for achieving broad policy goals without needing a big legislative fight.
So here is the final provocative thought for you to consider. You now have $50 billion worth of motivation to track your own state's performance. Your state, having promised major legislative changes like con reform or new health mandates to get this money, is now required to deliver over the next 5 years. This whole discretionary program runs on performance. And if they fail to pass that legislation, they risk losing millions in that crucial merit scholarship funding.
So keep a close eye on your state legislature's health committee schedules for the next few years. The price of policy failure is now calculated in the hundreds of millions.